In the last video, you saw my management of a cord prolapse with birth being imminent. So in this one, I'm going to talk about how I would manage cord prolapse if the birth was not imminent. But before I get to that, I want to, in the last video, I gave the instruction for someone to call EMS. So I want to give an example of what that phone call would sound like, as well as a phone call to the hospital. Okay, so yeah, here it goes. So this is 911. Hello, my name is Joanna Grimes, and I am a licensed midwife attending a home birth at 9742 Narrow Gauge Road in Beulah. My phone number is 517-648-4102. I have a client in labor. Her water broke about 2 minutes ago and there is a cord prolapse. We anticipate needing emergency transport to Traverse City Munson Hospital. Birth is imminent, so we are preparing for neonatal resuscitation. We just want EMS to be here in the event that we need to transport the baby after birth for further resuscitation or care. So I'm going to get off the phone with you now and alert the hospital of the situation, and yeah, that's it. Of course, I'd answer any questions they had, but that's pretty much how that would go for the hospital. Okay, now I'll call the hospital. Hello, my name is Joanna Grimes. I'm a licensed midwife at a home birth in Beulah. I have a G5P4 in labor. Her water broke about 4 minutes ago with clear fluid, and there is a cord prolapse. Birth is imminent, so we are preparing for neonatal resuscitation, and we have EMS en route in case we need to transport the baby after birth. So I just wanted to let you know because we may be coming in and needing a NICU team. I will get off the phone with you now to attend the birth, and I will call back if we are transporting and give you an update on the situation as well as an ETA. Okay, thank you. So that's basically how those phone calls would go. And then as far as how management would be different for a imminent cord prolapse, or an imminent birth and a cord prolapse and a non-imminent birth, a lot of things are the same. So I'd still have the client get into a knee-chest position. We'd still keep auscultating fetal heart tones. I'd want to auscultate those as continuously as possible. We'd still have a oxygen mask for the mom at 10 liters a minute. And of course, I'm still going to do a vaginal exam. That's how I'd confirm that birth was not imminent. And once I confirmed that, then I would keep my hand in place. Of course, this is with a sterile glove. I'd keep my hand in place and using my hand, fingers or hand, to push the baby's head up and off the cord to allow that blood flow. I would instruct the client to pant or blow if they did get the urge to push, and also explain to them that this was an emergency situation that we needed to transport to the hospital as soon as possible for an emergency cesarean. Something else that's different is that if birth was not imminent and the cord, there was a frank cord prolapse, I could see the cord in the vagina, or coming out of the vagina, then I would attempt to tuck the cord back up in and kind of hold it there while I'm holding the head off the the cord, or if that wasn't possible, then I could get some sterile gauze wet with normal saline, preferably warmed normal saline, and put that on the cord to keep it from drying out. And then we would transport, we'd get the EMS there, and we'd transport in that knee chest position with me continuing to keep my fingers or my whole hand in the vagina to keep the baby's head off the cord. And we'd stay in that position all the way until we got into the OR, where they could do the emergency cesarean. So yeah, that's it, I guess.